Well, hello, everyone. This is Nicholas Hall, founder of Graham's Foundation. I'm here with Peter Davis. You're going to notice right away that his accent is different from mine, and he's actually we're traveling in time because he's a day ahead of me. You're in Australia, if I'm not mistaken, Peter.
That's right. Yeah.
Great, and you're based in Melbourne. Is that correct?
Yeah. Yeah. No, I've been in Melbourne for 30 years or so now, Nicholas. And yeah, great part of the world if you're ever on the road and looking for a good
I,
cup of coffee. Come to
yeah, I appreciate that opportunity. I might take you up on it. If you could, with our community, if you wouldn't mind sharing, a bit about your background, kind of where you're a neonatologist, where you're practicing today, where you're focused. That's going to obviously lead into our discussion today around resuscitation and breathing and just the innovations that are happening in the area of just in breathing and et cetera when it comes to premature babies.
Okay, so I drifted into neonatology sort of very accidentally as a young doctor. It was firstly, I think the immediacy of neonatal care, the ability to make a difference just um, in seconds. You know, baby comes out not breathing with a no heart rate or a very slow heart rate, and just by doing some simple things, you can make that make a big difference to those babies. Suddenly they're crying and pink and
Yeah.
everything's good. So that's a bit shallow, I guess, but that instant gratification aspect got me into neonatology in the first place. I went to Canada for a fellowship, and then the only job in Australia when I was finished was in Melbourne. So I've been in Melbourne for 30 something years now, and a mixture of clinical work and research, and I'm still doing some work in the delivery room and in the intensive care unit, which I really enjoy, just the face to face with the babies, with the families, and so it's a nice mixture of clinical work and research.
And is the clinical research, is that in addition to the practicing by the bedside, is that more of an expectation within the healthcare system in Australia, or is it in particular the unit where you are? Is that something? I know you mentioned that there was a job there. I don't know if everybody is expected to sort of to do the research, or is that more a nature of the system?
Yeah, that's changed over time. 30 years ago, there was certainly no expectation to do research, but I'd sort of caught the bug in Canada. I was at McMaster University, which is the Centre of Evidence-Based Medicine. So I learned the language of clinical research, and I came back sort of with some enthusiasm for answering some questions. And so I started off in a very small way, just little randomized trials. And over time, Australia's been pretty good at collaborating between individuals at a single hospital and then between hospitals to answer the big questions. And so it's been a pretty fertile ground for research. So it's been a sort of an organic thing where over time, I think Australians have been big adopters of evidence-based medicine, and therefore the need to gather research to inform our clinical care. So it's been a good place to work.
Great. And in the area that you focus, maybe if you could share a bit more, where you're focused today, and has that always been an area of interest, or is that sort of developed and morphed over time as well?
Yeah, there was never a conscious intention to focus on any one particular field, but looking back now, the theme has been on supporting babies breathing, both in the first minutes of life and then in intensive care. So that's sort of the core of neonatal intensive care and resuscitation. If you can get the breathing right, most other things fall into place. And really, most of my career has been involved testing reasonably simple strategies, the non-invasive ventilation, CPAP, high flow ways of avoiding the heavy duty invasive things like an endotracheal tube, a tube down into the windpipe to take over breathing. So it's been simple things like that, things like caffeine to stimulate the baby's own breathing so that they can take over the work and we don't have to rely on our machines, which sometimes life-saving, but come at a
Right.
cost for the baby's lungs, as I think you know, Nicholas. And
Yeah.
yeah,
Yeah. I mean, um, that's my memory. So, my son Graham lived 45 days, was always intubated,
yep,
um, and never, couldn't breathe on his own. And my recollection, and as I understand it, is when a baby is born and not able to breathe on their own, like that's the milestone. Like if they can start to breathe on their own, then the rest of everything else will develop from there. But if they can't do that,
yep,
that's going to impact their ability. They can't suck, swallow, and breathe. They can't the stomach.
yep.
They're not going to be able to digest. I mean, nothing else is gonna work if they can't do that.
That's right. Yeah, no, it's pretty tough for parents sitting by the bedside with a baby on the ventilator. You know, it's I can't imagine how draining that is. How you know, it's just a high level of stress for the
Yeah,
baby. That can't be a pleasant experience, and for the parents, um, it's just very difficult, isn't it? And that's why the landmark events in a baby and a family's life is when the tube goes in and when the tube goes out, and so that there's a lot of stress attached
yeah,
to both of those events. Yeah.
yes. I remember one time the tube accidentally came out, and then
Yep.
being there in the stress
Yeah.
of replacing, and because they're so fragile.
Yeah.
I'm curious. So my experience was nearly 20 years ago now. It's hard to believe. How has how have practices changed over, and we can go, you can go beyond 20 years, but what have, if any, have been some of the breakthroughs, if you
Mm.
will, in approaches or in understanding, um, and has there been, I guess the follow-up question then would be, and I'll remind it if we don't get to it, but do we have a long enough of a runway to see any of the impact of those changes, even
Mm.
in young people, right? Have we seen improvements in lower rates of BPD or asthma or other types of longer term effects that are often common with babies that are born early and require breathing support?
Yeah, great question, and that probably has been one of the biggest changes over my career. And it just sort of happened. That period in the mid 2005 to 2010 was when we really there was evidence started emerging. We did a randomized trial here, and there was a similar one done in the US that showed that if you let the baby breathe for themselves, just gave them the gentle pressure up the nose, CPAP up the nose, they did better than if you put the tube down straight away. So CPAP, some caffeine to help them breathe would keep them off the ventilator, many babies. And so that was a big breakthrough. So when I started, almost every baby in the intensive care unit had a tube down their throat, and
Yeah.
we saw some horrendous lung disease, air leaks, pneumothoraces. It was all pretty ugly. So with the CPAP, that sort of I think gave babies a much smoother start to life. It didn't make the problems completely go away, but it did help. Yeah.
So at this point, I know enough from going to conferences where people like yourself are presenting, that,
Mm.
and I can remember it's probably been at least 10 years, if not longer, where there were presentations exactly what you were talking about of CPAP versus as an alternative to intubation and the positive outcomes. Is Are we at a point now in 2025 where um, intubation is quite rare? Is it now more in like a 20? Is it a 22 weeker or a 23 weeker where they're just so tiny that CPAP and caffeine just isn't sufficient?
I think that's right. For the majority of units in the world, and those that are attempting to resuscitate 22 and 23 weekers, those babies are still needing an endotracheal tube. Um, I guess the other thing that's changed is the way we give surfactant, which I'm sure your twins
Yeah,
received.
yeah.
Um, and conventionally, that was delivered via an endotracheal tube.
I
These
was going to
days,
ask again. I was going to ask you that. I only know enough to be dangerous to ask a question, but I was thinking, okay, surfactant. I know it's important. I assume it's delivered through the tube through intubation. How do they
yeah.
how does that work with the CPAP? Yeah,
So that was a big question for maybe a decade. Got CPAP, that seems to be good. We've got surfactant, which some babies seem to need, and that's also good. Can we give surfactant to babies while they're on CPAP? And the answer is yes. And there's been a series of trials where we published one 4 or 5 years ago. You leave the baby on CPAP, you can pass a very thin catheter down between the vocal cords while the baby's still breathing and squirt the surfactant down, pull the catheter out, the baby keeps breathing. And so that sort of revolutionized the care of babies, certainly 25 weeks and above, maybe 24 weeks and above.
yeah,
You get the benefits of both the surfactant and the CPAP. And that's translated into better numbers. BPD, which is something neonatologists get quite excited about, but parents, less admissions to hospital, less
yeah.
wheezing illnesses in the first couple of years of life. So that seems to have been a pretty big breakthrough, that combination of treatments. Yeah.
Yeah, and we parents know getting admitted to the PICU is not as friendly as your. It's a it's a much it's a tougher situation. As hard as the NICU is, the PICUs are even tougher. Did the companies that supply surfactant, did they have to make any changes to their formulation or to their product based on how you deliver it with a CPAP?
No, that was the only innovation that was required was a good catheter to deliver the surfactant. It's the same product, but initially we were using a vascular catheter, a catheter that would normally go in the vein of an adult. It had the right properties, but not purpose built. But
Yeah.
since those first days, there's become better catheters available and with markings on them, so you could tell exactly how far to put it in, so that it'd go into the right place. But with all of those developments, it's become quite a popular and universally accepted way of dealing with these little babies.
Oh, that's fantastic. And so it sounds like it's been a practice long enough that you are able to like real world see the difference that's making in terms of lower cases of BPD and some of the other issues
Yeah,
that you saw before with babies that were intubated.
yeah. I think overall we're not seeing BPD and we're not seeing lung growth into children and adolescents. We're not seeing hugely better results, which is disappointing for us. I guess part of the reason is that we're the fact that we're resuscitating smaller and sicker babies explains that. But it just tells us there's more work to do. We've looked for a silver bullet for preventing lung disease, and it just hasn't happened. We get these incremental shifts, things like surfactants, things like caffeine that shift the needle a little bit, but still plenty of work to do.
Is there any research that you're involved or that you're aware of that that could be the next, potentially the next breakthrough? I mean, I guess surfactant was certainly, if you go back in the time machine far enough back, nobody was talking about surfactant.
Mhm.
And so what you're able to do today to save babies wasn't possible. And now it's like it's possible, and there are potential side effects, obviously, with every medical intervention. Yeah,
Absolutely.
is there anything in particular that you and your team are working on today or curious about, or even that you're just aware of because you're in this particular field that is that's taking place?
Yeah, a few things. Well, we've had a recent disappointment. We had hoped that mixing some steroids in with the surfactant in those early hours of life might dampen down the inflammation of that occurs in the lungs and lead to better outcomes. Unfortunately, we just completed a trial and a similar trial in the US, which hasn't lived up to the promise. So we need to keep thinking. In terms of the delivery room, we're looking at different oxygen concentrations. We know that too much oxygen probably damages the brain and the eyes and the lungs.
Yeah.
Too little, and the babies seem to need more respiratory support, and that in itself causes lung damage. So we're working on what's right for babies in those first critical minutes of life. And I suspect it's going to be quite a high starting point of oxygen to help the baby become pink, start to breathe, and then backing right off. So that's something that needs testing. We're looking at helping babies start to breathe before we clamp the umbilical cord. So using
Wow.
the yeah, so the umbilical cord, a lifeline in when the baby's inside. The practice had been to cut it straight away as soon as the baby was born and move the baby to the to the resuscitation trolley. It turns out that that's probably not a good thing to do because it really destabilizes the baby, the cardiovascular, the heart and the blood vessel system. If you suddenly clamp the cord, it really makes it difficult for the baby to make that transition. So if we delay the clamping of the cord and perhaps give a minute or two of breathing help to the baby while the baby is still attached to the cord, that makes for a smoother entry into the world and perhaps better long-term outcomes. So that's sort of a work in progress, but it's a really simple idea, but it seems to be bearing fruit.
Now, how I know I'm curious, and I think perhaps our listeners might be curious as well. So, simple idea, right?
Yep.
How long does a simple idea like that actually take? Like, what does it take to actually
Mm.
be able to do that? Like, is there a process? And
Yep.
I assume if you're going to change a practice, there has to be approvals or and then
Yep.
measures, and are we talking
Yep.
weeks, months, years?
Yeah, decades quite often, and so
Yeah,
for good reason. I mean, people have been having bright ideas for a long time, and some of those bright ideas do bear fruit. Others turn out to be disasters.
yeah,
But particularly in neonatology, we've been through our share of um, big problems. The one that's probably most famous is giving oxygen to babies who are breathing irregularly. Makes them nice and pink, helps them avoid the apnea that I'm sure you've
yeah.
experienced, but leads to the severe eye damage that can cause blindness through retinopathy of prematurity. So that's made us really cautious. It seemed like a really good idea. Babies are short on oxygen. Let's give them plenty.
Yeah.
Problem solved. But it was a disaster. So now we take things very carefully. So something like this delayed cord clamping and resuscitation on the cord goes through a period of intensive animal work, so that we work with our physiology colleagues on a sheep model. So getting the bugs out there, seeing what's happening to the circulation around the time of delivery, then really carefully introducing it in practice in the form of randomized trials. So, half the babies get the standard treatment, half the babies get the new treatment. And you need more than one of those trials done in more than one setting. So works in the UK and Europe. We want to see if it works in Australia or in the US. So it's quite a careful examination of anything new that comes along. It has to prove itself in randomized trials, and then meta-analyses of randomized trials. Then it's put to resuscitation councils, and they evaluate the evidence and come out with their recommendation. So nothing
Yeah.
ever happens from one day to the next, but we need to be careful. Yeah.
Is there anything that you're aware of that's an application that's outside of a practice per se that you're working on or involved in or aware of? Again, obviously
Yeah.
within your area.
I guess something that's been bubbling away now for several decades has been stem cells in all areas of medicine, but would seem to be particularly helpful for preterm babies who are still developing, who have scarring of their lungs, sometimes damage in their brain. The
Yeah.
possibility that stem cells might be able to regenerate normal structure and function of particularly the lungs and the brain. That's still work in progress, not ready for prime time, as the Americans say, but that is one light at the end of the tunnel.
Yeah, I know a lot of certainly plenty of parents have experience with their babies having a brain bleed. Um,
Yeah,
we did, and you can't tell where it is necessarily. You don't. Sometimes they resolve, sometimes they don't. You just don't know what
yeah.
the impact is going to have long term, and it's time. Time just only at this point that I'm aware of, time just kind of tells what the effect of those
Well,
brain
it's
bleeds
really
are.
difficult for parents, isn't it, to handle that uncertainty. Difficult for the medical and nursing staff as well, but particularly for parents for us to say, look, there's been some bleeding. We can see a shadow on the ultrasound. We're not quite
Yeah,
sure what it means. We're going to have to watch carefully. Yeah.
yeah. Is there so you shared about that the ability to make an immediate difference. Um, that's still does that still make a difference for you? Is that still important for you?
Absolutely. Still a very shallow person, Nicholas. But
Not very
it's very,
for parents. It doesn't occur as very as you might imagine. It's not shallow at all. It means
yeah.
all.
No, I'm being a little bit facetious, but it is nice. Most of our patients do very well. Babies are very resilient, even the tiny ones. We we find that they're very forgiving of our mistakes. Um, but yeah, no, I guess what's happened to me over time is that yes, the immediate resuscitations and the highs and lows of intensive care are still there, but that sense of being some help to parents in their journey, and sort of knowing what they need, or having a better sense of what they need to stay sane over that 3 or 4 month journey. That's a real privilege to be part of that team.
Well, I know that part of what I shared is I appreciate being able to talk to people like yourself that are doing the work, and it's long-term work to be able to have an impact and make a difference for these babies. And they often say the best for far too long I was involved in like technology and software and all that stuff, and they say the best technology is the technology that it just works. You don't know it exists, right? You don't have to interact with it. And I think the same can be said in the area of neonatology, that differences, like I said, a parent that goes in today, they're not going to know that 10, 15, 20 years ago, babies were all intubated. And now
Mm,
it's, and there's been this
mm,
breakthrough that's making a difference. They
mm,
just know they just know what they know. They see what they see.
mm,
And so I know that there's work being done across the field in all areas because I talk to your peers and I attend the conferences. So I know it's slow. I know it takes commitment and stick to itiveness, but I also know it really is making a difference for a lot of parents, families, and obviously those babies. Is there, before we wrap things up, I guess I always like to give you an opportunity to, you know, anything that you would share with the parents, right? Just you've interacted with probably thousands, right, of parents over this point in time. It can be incredibly intimidating for parents. They can be afraid to ask questions. They can be because they don't know the beeps and the words and the language. And I guess with all with all of that, are there any bits of advice or encouragement that you might share for our parent
mm.
population?
Yeah, certainly two themes emerge very early on. Often we're talking to parents either just before or just after delivery, and so what I would normally say to parents is it's particularly mothers who think, "What have I done to cause this?"
Yeah, yeah,
And so to say it's not your fault, it's nobody's fault. We're here where we are for reasons that are beyond your control and beyond our control. But you're in the right place. We're here to help. We're going to be a team going forward. There's going to be a lot of strange words and strange technology that you're going to be exposed to, but we're here to help you through that. Very quickly, you'll become experts
mm,
uh, in that technology, but more particularly, experts in the care of your baby. So the things that you can do to help for the mothers to be expressing and providing milk for their babies, to be singing to their babies, to be touching their babies, to be stroking their babies. And now, I mean, one of the biggest breakthroughs in the last 30 years is the fact that intensive care babies come out into their mothers and fathers' arms and spend time skin to skin.
yeah,
And we know that that's a really important thing. It's stabilizes the babies. You can see their heart rates go down, their oxygen levels go up. So we're going to be part of this team um, for your baby going forward. We'll tell you when things go wrong, but
yeah,
you ask us questions, you can ask us anything. Um,
yeah.
yeah,
No, it's so that that means it means the world. I know that wasn't our experience, I said nearly 20 years ago. And I know that's really changed that approach to skin to skin and encouraging parents to get involved in all the ways that you shared. It's not only good medicine for the baby, it's good medicine for the parents as well,
absolutely.
right? So we need it. We need different kinds of medicine, but we need it as well. So
Well, I think there's a whole new literature. I've been involved a little bit in this in the effect of this experience on both families. I guess we picked up that it was affecting mothers, and there's always been this concept of postpartum depression and
yeah,
anxiety, but to see equal, sometimes worse levels of depression and anxiety in fathers who've been through this process, and to first step is to recognize it and measure it, and then to think about ways that we can make that journey easier, like reduce those rates of stress for the parents. And I think involvement uh, in their care is a big positive. Sometimes that doesn't always come
yeah,
naturally. There's a first impression. How could I cuddle this
yeah,
this this 600-gram baby? Please leave it in the cot.
yeah,
I don't want to break my baby, but with reassurance, we make progress. Yeah.
yeah. Well, Peter, again, thanks for your time and your insight and your commitment to preemies and their families. We really appreciate it.
It's been a pleasure, Nicholas. Keep up the good work. You're doing great work.
Thank you.